Tracy Morton at the National Rural Health Resource Center, and welcome to the August TASC 90 webinar. We're really glad that you're able to join us today, and we look forward to a fun conversation, really beneficial hopefully to the state flex program, about closing up your program year this year and then preparing for the next program year that starts on September 1st. The webinar is being recorded today. It'll be available for playback shortly, and also our webinar recordings are also available in podcast formation if you're interested in taking it on the road with you as well. I'll go over the agenda for today, and then we'll move into our quick updates before we get into the topic of conversation today. So we'll start with a brief update by myself here about what's going on at the Technical Assistance and Services Center. Then Sarah Young and Joaquina Scott from the Federal Office of Rural Health Policy will be providing an update about critical access hospital regulatory items, as well as any other updates from the Federal Office of Rural Health Policy. Laura Grangard-Johnson is joining us from the Rural Quality Improvement Technical Assistance Team, as well as the Rural Health Value Team, to provide an update on some of the new resources and items available from those two programs. Kristen Ryder with the University of North Carolina at Chapel Hill will be providing an update about the Flex Monitoring Team, and then we'll move into our educational content for the day. So to begin, a few short updates from TASC. Thank you very much for all of you that attended the reverse site visit in Bethesda just a few weeks ago. It was really wonderful to see everyone have the opportunity to connect. Thank you to those that did complete the online electronic assessment post-event. We were really pleased with the results. As you know, we did a pre and post test, and we were able to see that there was knowledge learned from the assessment results, and also that there was an increase in confidence about communicating on the various topic areas that were asked in the questions, which was absolutely the goal of providing that educational content, besides just the opportunity to network with each other. So we're really pleased with those results. The resources, the presentations and such are posted on the TASC website in the events page. If you're looking for any of the content, please do reach out to us if you have any questions. As you go to the TASC webpage, you'll notice some changes that have occurred. So we've been rolling out some gradual changes in how our website functions, as well as how it looks. There's an improved resource library and improved search functionality. There's some new layouts that you'll observe. There's also more improved descriptions of the resources, what you're looking at and what kind of format they come at, be it a webinar or a PDF or a Word document. There's improved event listings, including all of our upcoming events, but also a catalog of past events that are searchable too by program and topic. And there's also a news feature, among many other things that are available on the website. In the future, we'll be rolling out some topic collections, and we're really excited for that. If you have any feedback, on the top corner of the TASC website, there's an opportunity to provide any feedback or thoughts on the website. And we'd love to hear your thoughts and your interest and what you're looking for, or any challenges you might be having too. Two educational opportunities that are coming up to share with you. You would have received an email notification yesterday about a webinar on August 30th that's being offered through the Small Rural Hospital Transitions Project. This spring, they hosted a summer in a joint effort between the Small Rural Hospital Transition Project and TASC, looking at operationalizing some key strategies in rural hospitals transitioning to value models. So this webinar on August 30th at 12 p.m. Central Time will be sharing the results of that summit and the tools and resources that were developed. Unlike normal Flex program related webinars, registration for this webinar is required, and it is available to the top, or the first 100 registrants. So if you register a little bit later and the slots are all filled, do know that it will be recorded and will be posted for playback as well. Sarah Young will be talking about another webinar that's on August 30th too, so I'll let her inform you of that. But one last educational opportunity to mention to you is the next Flex program workshop will be October 17th through the 19th here in Duluth, Minnesota. Registration will be opening for that too. And the target audience for that Flex program workshop are new state Flex program personnel, as well as those that have been with the program for a while that are looking for an update and educational items related to certainly the Flex program, but kind of all things rural health related too. So if you're interested in the workshop, you want more information in between now and us sending out a message about the workshop registration being opening, please do feel free to email us at task@ruralcenter.org. And with that, I will turn things over to Sarah Young and Joaquina Scott for the FRHP update.
Thank you, Tracy.
Hi.
This is Sarah Young. My one quick update for the FLEX program, as Tracy mentioned, in addition to the technical assistance webinar on August 30th, I've sent a save the date out on the FLEX listserv for a FLEX Notice of Award Review and PIMS Update webinar, which will also be August 30th at 2 p.m. Central Time, 3 p.m. Eastern Time. So we will have a busy last week of August, and look forward to talking more about those at that time. With that, Joaquina, you have some very relevant CAW-related policy updates.
Yes, thank you, Sarah. So many of these updates I provided a few weeks back at the reverse site visit, but I felt that they were worth mentioning again on today's webinar. I'll first start off with the finalization of the fiscal year 2018 inpatient prospective payment system rule, which is effective as of October 1st this year. And so again, as a reminder, some of the policies that are significant for rural health, for critical access hospitals include de-emphasizing the review of the 96-hour certification requirement. So by way of brief background, for inpatient CAW services to be payable under Medicare Part A, the statute requires that a physician certify an individual may be reasonably expected to be discharged or transferred to a hospital within 96 hours after admission to the CAW. So CMS received lots of feedback from stakeholders, including CAWs, regarding this particular policy, which CMS has provided feedback on and policy changes in the past. And in doing so, what they're doing is just, again, finalizing that they're not going to look closely at CAWs following this particular rule, and would like to reduce burden for CAWs if possible. So again, they are basically saying that they're not going to, or they're providing notification to their QIOs and their MACs and their medical review contractors to make the CAW 96-hour certification requirement a low priority for medical record reviews conducted on or after October 1st, 2017. And so the only way that they would maybe consider reviewing medical records is if there is concern about probable fraud, waste, or abuse. So again, they finalized that, and that's going to be effective October 1st, 2017. Also are finalizing establishing about $7 billion in disproportionate share hospital uncompensated care pool payments to be allocated according to worksheet S10 data. And also, they've also finalized that eligible CAWs participating in the EHR incentive program will have to report on at least 4 self-selected measures for the continued quality measures. So I wanted to just kind of bring that to your attention. Also, for the quality payment program, I think the thing of the most significance for CAWs is the proposal to increase the low volume threshold to $90,000 or 200 or fewer Part B beneficiaries. So in effect, excluding more rural providers or method 2 CAWs, for example, that may or may not have to participate in the program based off of the new threshold that they are setting. For the outpatient prospective payment system rule, again, that is out as a proposed rule now, and they are accepting comments through September 11th. And in this particular rule, CMS is reinstating the non-enforcement of direct supervision requirements for outpatient therapeutic services for both forecasts for the calendar year 2018 and 2019, and this is to allow these facilities to more time to comply. So again, there's the opportunity to comment through September 11th. And then finally, for the physician, also before I leave off of the outpatient prospective payment system, I did not mention on the slide here, but of course, part of this proposed rule, they have proposed reducing reimbursement for 340B purchased drugs from the average sale price of plus 6% to the average sale price of minus 22.5%, which could disproportionately affect rural hospitals given the smaller margins and finances and strained finances. However, critical access hospitals will continue to receive that cost-based reimbursement for their 340B purchased drugs. So as Sean Supplett mentioned during the reverse site visit meeting, so it's not, this proposed policy is not affecting critical access hospitals yet. So certainly it is something for you to pay attention to, and CMS is open for comments from all providers and stakeholders related to their proposed policies. And then finally, moving on to the calendar year 2018 physician fee schedule proposed rule of significance for rural providers are the creation of the general care management bundled code for particularly for rural health clinics and SQACs. And what this code is trying to achieve is allowing such facilities to be able to bill for a more complex level of care or complex level of chronic care management services for their beneficiaries. Typical physician offices are already able to bill for such complex chronic care management codes, so this is really allowing RACs and FQACs to be able to do the same thing, but at one bundle code using one code versus 2 or 3 different codes that would be billable on a physician fee schedule side. The other thing that CMS did for this proposed rule was update the Medicare diabetes prevention program. And again, this is a program that really establishes a new Medicare supplier and allowing more lay people such as community health workers to be able to participate in the Medicare program by providing diabetes prevention education to Medicare beneficiaries. Of course, it's a 2-step process where first they have to be affiliated with an organization that has been received accreditation from the CDC to participate in the Medicare diabetes prevention program, and second, they have to be a Medicare provider. So we're trying to, get the word out that this is a new program. It does not require staff or providers that have higher level of clinical experience, and I think that it could be something definitely beneficial for rural communities that tend to see higher rates of diabetes overall. So I'll just stop there to see if there are any questions related to these updates.
Thanks, Lakina. Is there any questions at all? Okay, hearing none. A reminder, if you're ever looking for the federal update or the regulatory update on the TASC website, as you go to the website, on the right side of in the menu bar, there's a link for regulatory update and federal update. Those updates are provided each month by Sarah and Joaquina, and they're provide a lot of different hyperlinks and things like that. So if you're ever looking for kind of the latest information from FOHP about Flex or CH regulations, please do look there. With that, I'd like to invite Laura to provide the update on Arquita and Rural Health Value. Laura?
Thanks, Tracy. This is Laura again with both Arquita and Rural Health Value, and both of those are FOHP-funded agreements. We're just housed at Stratus Health in Minnesota. And like Joaquina, a lot of this will be a review from the reverse site visit, but it seemed important to look over again. So I welcome any questions you have following that. I'll skim through this. So a reminder just what ARKITA is. We're a cooperative agreement, and we're entering into our third year here with FRHP, and our goal is to improve quality and support you as Flex offices in working with MB-QIP. So what I'm going to do is just do a quick review of what we're available to do for you, what we've put out so far, and what we're looking forward to in this next year with the ARKITA update. So just a quick snapshot, MB-QIP is available, or ARKITA is available for technical assistance. We've received over 800 TA requests since the beginning of providing assistance, approximately 50 per month, most commonly ED transfer and outpatient. We've offered Flex consultations, so those are more in-depth conversations with Flex offices. Those range from hour-long conversations to more in-depth technical assistance with questions you might have. Then in cooperation with TASC, we've done MB-QIP orientation calls for new staff that you might want to get on board. And we've offered 40 presentations as well. And what I'd just like to remind everyone here is if you'd like to request a consultation, presentation, or orientation, we're happy to provide that. You can reach out to Jody Winters at the email address listed on this slide. And if TA requests come up, our flow is to go through TASC with that, so you can email task@ruralcenter.org, and we'll get connected as appropriate to answer your questions. Just a recap of the tools and resources that are available to you to date. I think these are in the file share for download in one document as well for links. This is what's existing. In general, we put out MB-QIP monthly, each month for critical access hospitals specifically. We have measure fact sheets that outline kind of an easy to digest way the measures that are part of MB-QIP. Specific to reporting, we offer an MB-QIP reporting guide on a little bit more detail on how that flow works. This year we've released abstraction training videos that Robin has put out, as well as office hours from Robin. Specific to that, I'll just put this on your radar. Our next office hours, this is for hospitals, is September 20th. If you'd like to distribute that to your hospitals, please feel welcome. You can find that, again, linked in, information on how to do so linked in the resource list in the file sharing. That does require registration, but it is free. And we also have ED transfer communication tools available to help with reporting. Regarding improvement, we have a few resources on how to use data, specifically the MB-QIP data reports. We've put out an improvement guide and toolkit for critical access hospitals to help them get up to speed on what they might need to learn or know for improving based on their data. And then this past year, we put together a group of high-performing hospitals in HCAHPS and did focus group interviews with those, and the HCAHPS best practices linked there under improvement is a summary of those best practices. I believe this upcoming month there will be a briefer resource that summarizes those in a shorter format. And then specific to Flex, there is a handful of resources here. There's a ED transfer comparison template that lets you load your ED transfer communication data into a format that lets you look at how your hospitals are doing in comparison to each other and look at them over time. A few Flex program guides on how you can work with developing peer mentoring programs for MB-QIP. And then one specific to Flex on using the MB-QIP Excel files that you receive each quarter from FRHP. For those of you that are working with hospitals and helping them get on board with MB-QIP, there's a list of talking points that you might consider using when you have those conversations. And then we put together a list of monthly reporting reminders that you can distribute to your hospitals. Not mentioned on here as well that's ongoing is the virtual knowledge groups specific to MB-QIP. And I'll put this on your radar as well. Our next one is coming up next week, August 17th. And it will be focused on the antibiotic stewardship programs. We'll have a guest, Arjun Srinivasan from the CDC on that call as well. Moving forward to what's coming up in this next year, and I think I misspoke and said we are in our final year. This is the second year, so we're planning through a year of work here. Upcoming, we have updates to the IMBICLIP reporting guide. So with the new measures that are coming with antibiotic stewardship and ED 1 and 2, based on that as well, we'll be adding to the QI improvement guide and toolkit. And then depending on what we identify as needs to support those new measures, we'll be developing or compiling those. We'll be putting together a patient and family engagement resource in coming months. We'll be pulling together a technical expert panel review for the ED transfer communication measure. That's in partnership with the University of Minnesota Rural Research Center, which is the owner for that measure. We'll be working on an inter-rater reliability pilot project, looking at the validity of data that's entered for these measures. And then we're working on a ECQM pilot, so electronic clinical quality measures, and we'll be sharing the findings from that with all of you once that wraps up in the coming year. And as I referenced, we are working on planning our year. A lot of you will have noticed an assessment that was sent out yesterday by Jody Winters, and we'd love to hear your candid thoughts on what's useful or not that we've produced, what's needed, what gaps we can help fill, what we might consider doing differently or better. Truly, we found this really helpful last year and would love to hear from all of you again. We'd like to have one assessment per state, so if you work closely with contractors, we'd love if you could coordinate with them to submit one for your state on behalf of everyone. That'll be due to us on August 25th. So with that whirlwind, I'm going to shift into rural health value really quickly. And rural health value is in partnership with the RUPRI Center for Rural Health Policy Analysis at the University of Iowa with support from several partners listed here. And it's really to look at research practice and collaboration that create high-performance rural health systems, focusing on value. And the main things I'd like to highlight here, just specific to you, are resources on our website. The website has been revamped a little bit to make the front page a little more intuitive with what might be most relevant to you. So I'd encourage you to check that out, ruralhealthvalue.org. And I'll highlight just a handful of resources that have changed since the last update. One is the catalog of value-based initiatives for rural providers. That was updated, I believe, within the last couple of days. And it's a compilation that we're constantly updating that has one-page summaries of value-based programs that are appropriate or relevant for rural. We're up to about 28 programs that are highlighted there. It's helpful to point to your community partners or to use to become familiar with some of those programs. And then newly released is a guide to selecting population health management technologies for rural health care delivery. That is kind of a modular-based toolkit that can help you walk through the questions you might want to ask as a hospital in identifying population health needs. So a couple of things there that you might want to point your hospitals to. And I'll also note we just released the State Innovation Model summary, just preliminary results of some rural relevant summaries. I believe both that and the catalog are linked in the F4HP updates that were sent out today. So that was really fast. I'd love to take any questions that you might have, or feel free to send them my way.
Thanks, Laura. Are there any questions for Laura about ARKITA or IMBICLIP or rural health value? Okay, well, thank you for taking the time to join us, Laura. We appreciate it.
Thanks, Tracy.
So we'll move into the last update for today, and that's from the Flex Monitoring team. And Kristen Ryder will be providing an update on behalf of that group.
And Kristen, you will need to press *2 to unmute. We had some feedback, so I had to mute the lines.
Okay, thank you. Can you hear me?
Okay, this is Kristen Ryder from the University of North Carolina at Chapel Hill with a quick update from the Flex monitoring team. Like the presenters before me, all of this will probably look familiar. You should have received an email from Alex Evanson not long ago with an update on our projects, and then some of this was presented at the reverse site visit. I'm going to start by walking quickly through, how do I advance the slides? Sorry. There we go. Quickly through the special projects we have for our final fiscal year of our funding. I'm going to start with the University of Southern Maine. They have 3 projects ongoing, several of which are evaluations. So the first one is to continue evaluating the State Flex program impact and performance, and that includes an evaluation of some of the innovative projects that are going on, as well as an evaluation using the PIMS data. And you should expect there should be a final report at the end of the fiscal year, so sometime next summer. I'm not going to read all of this to you, but I'll just briefly summarize those. They have a second evaluation ongoing looking at different State Flex programs projects targeting EMS and the implementation of time-critical diagnosis systems. And they expect to produce a policy brief that will summarize some of these best practices and provide information for you. And then finally, they have a population health evaluation ongoing that will summarize the role of critical access hospitals in providing core health services in rural communities. And again, the idea is to produce 2 policy briefs that will help you understand the development of core health services by CAHs and the way that State Flex programs can help support development of these services in rural areas. So that's the University of Southern Maine. Our partners at the University of Minnesota also have a special project that they're doing this year, conducting a literature review, essentially, of evidence-based stroke quality improvement programs. And they will produce a findings brief as well once they've finished that, probably sometime next summer. We also have several projects that are ongoing as part of our 3-year grant. The first, again, is the University of Minnesota. They'll continue analyzing the quality data that are submitted through HCAHPS and through Hospital Compare and produce the quality reports that they send to each of the states at the end of the year. At the University of North Carolina, we're continuing our analysis of financial and operational performance indicators that are now included in COMPASS. These result in the production of the state medians report, which again will come out in the spring of 2018. We also continue to update and maintain our national database of critical access hospitals using data that we receive from CMS. And then finally, we're working on several new developments related to the critical access hospital measurement and performance assessment system. If you were at the reverse site visit, this will look familiar. One of the things we're currently working on is the development of a hospital and also a state dashboard for financial indicators that will allow hospitals and state flex coordinators to quickly view at a glance a summary of financial performance using data visualization such as this. This is just a mock-up right now, but it will allow sort of a one-stop shop to see how the hospitals are doing. Here we have performance on various measures presented in percentiles, so where an indicator falls relative to either national or state data that can be selected by the user. We also intend to have pop-up capabilities so that if you click on a bar or an indicator name, you can actually see the value for the hospital itself compared to several other benchmarks and or averages. The other thing that we're working on is a systematic way to draw attention of state flex coordinators to either hospitals or indicators that might need attention. And so we intend to look at the 11 indicators for which there are benchmarks and identify those hospitals that are meeting very few benchmarks, those hospitals that might be meeting most of the benchmarks, and those that fall somewhere in between. And similarly with the indicators, identify those indicators where a large percentage of hospitals are meeting benchmarks or where very few are meeting benchmarks, and give a quick visualization that would allow you to
to then drill down into the performance of selected hospitals. We're starting with the financial data and the development of these systems and dashboards around those financial data, and we hope to have a beta version for you to look at sometime toward the end of this calendar year. We're working on that right now, and we also have calls scheduled in the next several months to begin thinking about what quality and community dashboards would look like as well. So we hope to have those by the end of our fiscal year sometime next summer. Just in terms of data updates, right now all of the data are updated through 2015. We intend to do another refresh of Compass in the early spring of 2018, which would update everything to 2016. We also are hopefully going to be able to update the financial data sooner than that. So stay tuned. If we do, you'll get an email from the Flex monitoring team letting you know that those data have been updated. And with that, again, that was very fast and a lot of information, but if you have any questions about any of the projects or about Compass, you can always contact us at monitoring@flexmonitoring, and the email will get sent to the right person. Thanks. I'd be happy to take any questions.
Thanks, Kristen. So it's *2 to unmute your line if you have any questions for Kristen, or feel free to use the chat box as well. Those are some exciting things to be rolling out, in various different resources, but the Compass, new modifications and improvements to it and new dashboards sound really intriguing. So I'm looking forward to seeing those. Thank you. And then before we get into the topics for today, I know Yvonne Chow had an update that she wanted to share. So Yvonne, it's *2 to unmute your line.
Hi, Tracy. Thanks so much. I just wanted to also mention that on the outpatient proposed rule, a few measures are being proposed to be retired, and these are all essentially an overlap of the MBQIP measures. They include OP21, OP26, OP1, OP4, OP20, and OP25. And so I just wanted to let you guys know that this will be being proposed to be removed in the beginning of calendar year 2020 payment determinations and in the calendar year 2021 payment determinations. And it was an effort to alleviate maintenance costs and administrative burden for that. The second announcement I wanted to make is that CMS is actually hosting a webinar in about 2 weeks for billing for critical access hospitals and the quality payment program and its implications for critical access hospitals. And so this is a great opportunity to gain an understanding about the QPP program, as well as understand what critical access hospital clinicians may be eligible, as well as steps to take if you are a critical access hospital with eligible clinicians. And so that webinar is going to take place August 21st. It's on a Monday, 2 p.m. to 3 p.m. Eastern Time, and I will share the link down below in the chat box as well. And there's going to be an email being sent out through the MBQIP listserv, which will encourage you to submit questions that you may have and that we will then pass on to CMS. And hopefully they or the TA provider can help follow up and answer these questions on the webinar. Thank you.
Thanks, Yvonne. Any questions at all for Yvonne? It's *2 to unmute your line. Okay. Well, thank you. So with that, I think we'll transition then into the main topic for today, and that's helping the state flex programs kind of close out the current program year and then prepare for the next program year. And so we're going to have a joint presentation here, and Caleb is going to kick us off, but joining us today in the offices here in Duluth are Sarah Young and Mike McNeely. So it's nice to have them on site and nice that we can kind of do a collective presentation together. So we're happy to have them here. So with that, Caleb, I'll turn it over to you to kind of start the conversation today.
Thank you, Tracy. You can hear me okay, I hope?
You're a little quiet. If you can talk a little louder, that'd be great.
I can try.
Perfect.
Hello and welcome, everyone. This is Caleb from TASC. Thank you for taking the time to join us. Our presentation, this TASC 90 webinar, we wanted to talk about preparing for the next next Flex program year, which will start in September, as you all know. And we thought it would be a good idea to talk about going back to school, starting the new school year. I thought it reminded me when I was talking to Tracy one day about the beginning of the school year, where you need to find where your locker is. You need to find out your combination, find out what classes you go to, your new teachers, all that new stuff. But before you do that, you have to, there are a fair amount of things you have to do when you wrap up the current year. So that's what we're going to talk about today. And Sarah and Mike McNeely, as Tracy said, from ORHP, are here to talk about some of the more specifics and detail-oriented things having to do with your grant management. But I want to take a second to back up and talk about the center and the purpose of the National Rural Health Resource Center. So we're a nonprofit organization that gets dedicated to sustaining and improving healthcare in rural communities. We're the nation's leading technical assistance and knowledge center in rural health. And we focus on transition to value, collaboration and partnerships, health information technology, performance improvement, and workforce. So if you need any assistance with any of these areas, please don't hesitate to give us a call. So yeah, so the picture on the left there is you escaping the final day and then coming back to school. Maybe those are reversed. Maybe the cheering is the last day. But we wanted to talk a little bit about, using up the rest of your supplies. You've got, a box full of crayons that you bought at the beginning of the year. You got a bucket full of supplies that need to be spent and figured out. You told a fair amount of people that you're going to do some things, outstanding projects, and you have reports and, I guess, final presentations that need to be given. You'll figure out what your grades are, share that report card with your peers as well as others, and then you got to clean out your locker. You got to kind of wipe that slate clean for this year, close out your books, and then start the next year fresh. So our thought was to, when we're talking about using up the rest of your supplies, you want to identify any incomplete projects or that's identified, and hopefully that is adhered to, but sometimes there are cost savings that were not identified, changes in scope, changes in the plan as you go. So being on top of that now and speaking to your project officers, we'll hear in a bit, is very, very important to making sure you're able to close out this year well as starting the next year fresh. If, any funds that are going to be left over that you might be able to roll over, anything like that, it's a whole lot easier if you know what you're going to have and why they weren't spent and how you're going to spend them or how you propose to spend them next time. And then, again, appropriately allocating the remainder of your budget. So when you're looking to identify those outstanding projects, the first and best way is to look at your work plan. Look at what you submitted to ORHP as what you would do. If you have subcontracts, have they done all their work? Have you spent all that money down? The NCC application due mid-year, I think, is a really good way to kind of check a little touchstone, check base, check in, make sure everything's on track. But this is kind of your last chance to do that. So will you meet your project goals? Evaluation, are things on track? Are you going to be getting those surveys back from your participating hospitals, or are you getting data back from your contractors if you're using them? And as I said, if not, if you have questions, if you're able to look at your work plan and talk to your subcontractors and they've got 2 of the 12 meetings completed and they've only gotten half of the work done, now is the best time to contact your project officer as soon as possible, just so they can help identify a plan and a process into mitigating that.
And that's a really good point, Caleb. This is Sarah. We, as project officers, we really appreciate hearing from Flex programs right away about changes like that, so we can help you make plans to make changes and adjustments as needed and still meet your program goals. And the more advanced warning we have about what might be going on, the more flexibility we have to work with you to come up with a course correction plan that will meet the federal requirements and will really meet the needs of your state Flex program.
Can I interject one thing? Caleb kind of mentioned this too. This is Tracy talking about, finding out from your subcontractors where they're at. You likely have some sort of a deliverable coming from many of your subcontractors this month. Probably don't wait until that deliverable is actually sent into you, but you might want to pick up the phone and call them and find out what to anticipate so that you can start that planning now of, I'm going to have $5,000 left over in this project, or it's going to completely miss the mark because something happened, whatever. So if you're unaware or if you're even questioning, it's worth just a phone call to them. And so instead of waiting a few weeks from now until you actually get that documentation and then have a very quick turnaround needed.
That's a great point on good project management, Tracy. And from the perspective of your project officers and the federal office, those final reports and presentations are the primary thing we see as to how we understand what your work is doing and what kinds of outcomes you're having. And that was the point of the grant funding and of the projects and coalitions that you've put together over the year. It's getting those final deliverables completed, of course, making sure that your subcontractors get paid on time. If you have a quarterly reporting requirement to FORP, the fourth quarter is June, July, and August for the purposes of the Flex grant because we run off the grant budget period, and that will be due in September. But don't wait until September to start writing your quarterly report. That's your last chance to summarize for your project officer the work that you've done for the year. And it's also a good reminder to check in with your partners, stakeholders, and advisory groups, again, so they know what you're doing and can provide meaningful advice and input to the Flex program in your state. And in addition to those final reports and presentations, a good analogy for PIMS and the Flex Work Plan data table is sort of your year-end grades in school. This year, PIMS will be open for data collection from September 1st to October 30th, and that is the PIMS data report for the grant year that will be just finished in September. And so are you ready to do that report and to get it done in a timely and efficient manner so you're not scrambling at the end of October to finish? There goes the bridge again. And pulling together that PIMS data is an opportunity to see where you are on track, which improvement projects that you carried out with CAUSE in the past year had substantial results, which ones didn't really work as anticipated and should be rethought if you're going to try to tackle that problem again next year. And while you're doing that thinking, it's an opportunity to share with your project officer what makes sense and what doesn't in the data you collect for the Flex grant. Are there some measures in your work plan data table that really aren't quite getting at the outcomes of your project that you'd like to? Does someone have a question? Maybe it was just a accidentally unmute sign. And once you've had a chance to think about the outcomes of the projects that you've completed over the past year, really make a point of sharing that. We just heard a horn going from the lift bridge here in Duluth, and if you don't toot your own horn, nobody else will. So share those outcomes, share that data. Make sure you have a summary report to present to your advisory group or your department supervisor. Acknowledge the hard work of the critical access hospitals and other partners in your state. And successes is everything from testimonial stories to highly data-driven graphs and charts. And as a project officer, I would say we really appreciate when you share those successes with us too. The project narratives and work plan updates provide good, solid information about your activities and some of your data, but they don't always capture the human story very well. And that's what keeps us all inspired to this work, and it's also what inspires you and many of your partners. So share those stories. If you've got a great anecdote, post it on the Flex forum. I bet your fellow Flex coordinators are interested in hearing that as well.
I think sharing those stories too helps to solidify some of the partnerships that might be going on too. If you're acknowledging others for their work or acknowledging hospitals for going the extra mile or taking a risk on a project, even if it wasn't 100% successful but they learned a lot, it just helps to motivate either others to want to join in with the efforts or to kind of strengthen some of the existing work that you have going on as well.
Yeah, and you know, I certainly don't expect, and nobody at FORP expects every project to be successful every time. That's completely unrealistic. But we want to learn something from every project so we can get a little better next time around. Now, once you've waved that report card around and boasted to your parents, it's also, the year end is also a chance to regroup. Clean out your locker, organize your files, make sure everything is ready to start smoothly and efficiently for the beginning of the next grant year. And again, as Caleb mentioned, as project officers, we really appreciate timely updates on the status of your budget. If you think you are going to have some unexpected unspent funds in this grant year, discuss it right away with your project officer. And we can help you develop a plan to use those unspent funds as a carryover that will advance the goals of your Flex program and will meet the federal grant requirements. So that's kind of the things you should be thinking about wrapping up the end of the project year. Are there any questions or comments that people would like to share at this time? And press star 2 if you'd like to unmute.
Okay, so unlike the school year where we often get a break in between the end of school and the start of the school year, the Flex program continues. So we're in tandem wrapping up the current program year and should be starting to prepare for the next year as well. So, you know, we don't get the break to go to summer camp or go to the beach unless you take vacation. But I think the benefit to closing the program and starting the program and continuing that momentum is that all the information is really fresh in your head about what you did this last year, where you kind of stand with things, how your partnerships are, how your subcontractors performed, and you're really teed up well to start the next year with really good momentum because you are so fluent in everything that's happened. And once you refresh yourself with the work plan that you wrote many months ago now, you're ready to kind of go into running through the next few steps to get that program really well established into the new program year. So what we'll talk about now with kind of preparing for the new year are things like finding your advisor, knowing where to go for resources, how to gather all your supplies and fill up your backpack for this next year, knowing kind of where you stand, what are those grades that need to be improved, what are those relationships that need to be improved, what are the things that you need to be doing for the year, who do you need to be paying, because we certainly know that all this work doesn't necessarily come for free. When things are due and expected, who you should be relying on, who your peers are, your partners, and your friends, and then how to kind of monitor your progress through the year. So with that, first we'll talk a little bit about finding your advisor.
In this case, finding your advisor is about the relationship that is the Flex coordinator's relationship with HRSA. It goes beyond just being your project officer and your GMS. Think of this as how you're working with your hospitals and how you're working with other rural stakeholders. You develop a relationship, you work on it, you communicate, and hopefully things get done very effectively. And the goal is to make sure that even if there is a miscommunication, that we all get on the same page at some point. Your PO is your point of contact with program, and being that point of contact, they're your first line. They're your first line of help, first line of talking things through. They're there for you. They're not just there to regulate and administer. They're there to assist and provide technical assistance, as well as to be a sounding board. If you have an idea, share it with them. They might give you some good insight. Your GMS is more than someone hiding in a cube. Though a lot of times they're hiding at home because they telework a lot of the time. But it's one of those things that the GMS can help you get through. Get to know them. At the reverse site visit, Will gave a great presentation about from their team lead perspective. But the individual GMSs each have a story, each have unique personalities, let's say, that you should get to know them, not when things hit the fan all the time. It should be something that you know what's going on. That particular relationship is the one that's going to help you, especially towards the end of the year. Sarah mentioned unobligated balances earlier, and work plan assistance, but the GMS, they're the money folks. They're responsible for the budget, and reconciling program with grants is very important.
One thing I'm kind of hearing you say, Mike, is with developing that relationship, is that it's actually strategic for the Flex programs, because the cold calls, of course, the project officer or the grants management specialist are going to respond to or whatever, but if you have an established relationship already, those kind of urgent calls or when things are in a pinch or you really need to kind of work through something, when you know that person better, you're more likely to come to a more, a better outcome.
And they're actually more likely to do more for you. And it's just human nature.
Sure.
By creating those relationships and being able to not think of them as that person that controls my money,
Mm-hmm.
and that they're getting to know them will facilitate many things. That's how things really get done when dealing with grants, mm-hmm. is those one-on-one relationships. And so don't just call them when you have an emergency, because mm-hmm. then they're just going to respond to you as the person that always needs something right now. Mm-hmm. So try to head things off, communicate early, and then you'll be surprised at how responsive they are based on how you treat them.
It's actually probably a good strategy, even thinking too, like within a health department or something, that where there is a separate budget or finance office too, to like build that relationship with those people too, so they can help you get the contracts through or help you reconcile the budget and things like that.
Exactly. On the state level, your own finance office should be your best friend. Mm-hmm. Mainly because from the perspective of program, you're thinking about projects and getting things done. But that's only part of it. And we've gone over a discussion about budgets, about making sure we're spending dollars, identifying projects, and working together. In looking at hold that thought there. really
well,
lost my train of thought.
If you're trying to work on getting the budget though completed and
Oh,
you
yeah,
have
no,
these
that's
plans,
right.
I mean, you need to kind of have those relationships and you need to anticipate upstream. So if they need to be doing something upstream to help you make your work plan and your budget happen.
That's part of it, but also making sure that it shouldn't be a surprise that you have extra money.
Sure.
And that happens a little far too often because of not communicating directly to the finance folks. You're waiting for a report, or you have a monthly check-in. It's one of those things. The responsibility really comes back to keeping an eye on the budget throughout, so that those type of surprises don't happen.
So speaking of relationships, one of the many resources you have are us here at TASC and the Technical Assistance Center, as well as Flex Monitoring Team for data and ability to read some reports and create, help get reports out of Compass. Arkita, as we heard from today, with tons and tons of expertise and support on MBQuip, resources, and technical assistance here with TASC. And I don't think, I'm going to click through a little bit and we'll go right back, but one of the things that I know we've talked about here amongst ourselves, at least the last day or two here at TASC, was the critical access hospitals and the administrators themselves. I think that is a huge benefit and resource for any Flex coordinator, especially a new coordinator. There are going to be critical access hospital administrators who have been part of the Flex program for as long as it's been in existence, and they are a great resource and just someone to ask questions to. If you don't, if you have a question, they know what's going on. They're running a hospital, and they are the ones doing a lot of the work that we're here to help support. So getting to know your critical access hospital administrators, and that's CEO, CFO, quality director, CNO, whomever that might be. And you don't have to go on a site visit to every single one of them. That helps. But just a phone call. Say, hey, I'm Joe from wherever, and I'm the Flex coordinator. I may not have ever had the opportunity to talk to you, or I'm new. What are you guys doing over there? This is what I'm up to. I'd like to, just chat with you every now and then. That is a great benefit, and it goes back to Mike's point about relationships. I would always tell hospital CEOs, I come here so you'll read my emails. You don't ignore emails from people you know as often as you do from people you don't know who are just some weird person in the state capital in many cases. And these are rural people getting emails from weird people at the public health department. What am I forgetting, Tracy? Oh, so some of the other key partners, and we here at TASC work very closely with everyone on this list. So please know that they are very aware of and very supportive of the Flex program and all of the efforts that you guys as Flex coordinators and we here at TASC provide. The Hospital Association, RHI Hub, Rural Health Values, the SHIRT program, the SHIP program, NoSOR. There are tons and tons, and I'm sure we left probably 5 off the list because we forgot about them. Is that your more horn, Tracy?
Yeah, it's a busy bridge day today. Sorry. And we regularly update. You can hear me over the horn. The beginning of this webinar went through several resources from several of these partners, and that's one of TASC's roles as convener of technical assistance for the Flex programs is to make sure that we're all aware of all of these resources so that the thing you need is the thing that comes to mind when you run into a problem.
So build that backpack full of resources. We've heard a fair amount today. I think almost every one of these has been mentioned. The PIMS data collection tool, start filling that out now. September is going to be here pretty quick. The more data, the more time, the more familiarity you have with that tool, the easier it will be to put your data in, which means the easier it's going to be to get it out. Easy out of PIMS data collection tool means easy into PIMS. The Flex Work Plan data table that TASC put together is really nifty and should be a great, quick, easy resource for you to go look at and update as you start your activities for the next year. Critical Access Hospital Performance Access Assessment System, COMPASS, as we know, is a great resource and getting bigger and more robust every day. There's tons of other state-level data that you have access to. Flex Program Fundamentals resource, the core competencies for Flex Program Excellence. We recommend taking that every year as a Flex coordinator, so you're able to see the change in your program and in your own competencies in those 9 core areas. So if you need to focus this year on population health or the transition to value or contract management, you're able to devote a little bit more time to that and identify resources and webinars that you want to participate in. We fully acknowledge and understand that there are 7 webinars every single day that you can participate in, but there are only 5 hours in the day for webinar watching. So knowing where you ought to, in quotes, spend your time watching webinars, reading up on things, that is very, very helpful. So the core competencies for Flex Program Excellence is a great way as a guide for a self-assessment to say, oh yeah, I never even thought about that, but I do need, or our office could benefit from spending a little more time on looking at the transition to value or whatever that might be. And the Flex Logic model that Sarah talked to us a little bit about at the reverse site visit is a great way and opportunity just to zoom back, a little bit and take a good comprehensive view of what's going on and double check and make sure your efforts are in the right vein or link. And these are all links, so if you download the PowerPoint presentation in our little file share application here, you can download each one of these or go to the link and complete them or read them.
And that brings us to thinking about those grades. The Flex program isn't actually school, but we do have accountability for our spending of federal dollars, for providing the services and assistance that our critical access stakeholders expect and need from the programs. And part of that accountability is your federal notice of award. Everyone should have gotten their notices of award last week or this week, and a few even came out sooner than that. If you have any questions about that, feel free to contact your project officer or contact me. And remember, that notice of award is a binding agreement between the federal government and your organization, and that lays out the strings that are attached to your receipt of this federal money. We'll talk more about that on the August 30th webinar, where I really do want to focus on the NOA requirements and the federal terms and conditions. So please do mark that on your calendar. But while you're thinking about it, again, as part of your preparation for the next grant year for assessing needs both of your individual cause in the state and of your program as a whole, take a look at any grant conditions that may be on your notice of award. If you've got any, please do have a conversation with your project officer about them. We will also be reaching out to state flex coordinators to have calls and go over the contents of your NOAs. It's a 1 or 2 sentences listed in the terms and conditions on that document. And generally, you'll need to have a conversation with us about what we're really looking for to be sure that you're putting your efforts into revisions that meet the needs of the grant program and meet what your project officer is looking for. As Caleb mentioned, the core competencies is a great way to monitor your own progress and your progress as a program. It doesn't mean, I think there's 9 or 10 core competencies. It doesn't mean that one person does everything. That's looking at it from the level of your state flex program. Are these skills and abilities that you have as a team? And then in addition to assessing your program itself, assess the needs of hospitals in the state. It's good to regularly check in on your InpuCrypt data and evaluate trends. As Kristen told us, Compass will be rolling out with even new tools and resources, but there is already a lot of data in there. Some of it requires you to set up some of the trend graphs to look at changes over time, but you can do that. And which flex activities in the past year were really well received by your hospitals, and which ones maybe had low attendance. Beginning the next program year is a chance to regroup and redirect how you carry out some of those activities. And as well as developing tools for flex programs, TASC has a number of tools and resources on their website that are really developed for hospitals and other rural health leaders to use. Ones we wanted to highlight include the Population Health Readiness Assessment, which can be used by a hospital or by a rural health community leader to assess their status as an organization for population health, and the self-assessment for transition planning, which is really focused at hospitals and healthcare organizations looking to plan for value-based models so they can continue to participate.
All right. So with all things, knowing what is in your work plan and what it involves is key to your success. Realistically, at the beginning of the year, it's really good to go over each and every item that you've identified within that work plan, because realistically you haven't, it was submitted 6 months earlier, right? Think about, is everything in that work plan relevant still? Is that something that you really should be focusing on? You have a chance to adjust it at the beginning of the year. You have a chance throughout the year to adjust it if you're finding things aren't working right. It's just a matter of identifying it and, and communicating. Because when you look at the tasks that are there, we don't live in a static environment, and it seems things have been changing really quick lately. Priorities have changed significantly in a stream of tweets. And it's just, the reality is that we have to be able to adapt as needed. And with that, look at your work plans. Identify what you are going to do, what you may need to change. Develop a timeline. If anything, it's a timeline to give you target dates. It's not something that has to be hard and fast. It just has to be ballpark as much as possible. Project management is what your role is. And it's not to be the expert on everything. Use what you can from basic project management, coursework, webinars, items available, because really your goal is to make sure things get done. You're not responsible for doing them all the time, but you are responsible for herding the cats, let's just say. On that point about not being the expert, be prepared to pay for that expert so that you can provide the best benefit possible. Some of you have backgrounds in QI, some of you have backgrounds in finance, some of you just have general experience, and all that makes you qualify for a flex coordinator. Now, are we asking you to be that expert? No, but we are asking you to be the one that can find the expert, to execute what needs to be done. Think about your subcontracts, all right? The administration and preparation of your subcontracts is a big event. For some, and I know it depends on the state you're in, on whether or not you can get them out quickly or if it takes half the budget year to get them out. We understand that. But do what you can to maximize your efficiency. Monitor the deliverables. Is the subcontract going to be on time? Are they going to be able to provide what you need by the end of the budget year? Be aware of what's going to be incomplete and if you're not going to spend all your funds associated with it. You notice the theme of repetition here. We're talking about plan, monitor, react. That's pretty much the way, and it's going to be, that's reiterated throughout this back to school lesson. Use the resources you have available. The center has created a great grant project lifecycle guide, and there are a number of other resources that they have available that have been very beneficial in really trying to navigate the minefield that is contracting, especially on the state level. The other thing you need to be aware is know your due dates. Everything when it comes to program, we have dates that have been established. We plan our dates out 9, 10 months in advance at minimum, usually longer. A lot of the dates are standing dates. We take a lot of things into account when we plan specific dates. We look at potential vacations for people. We look at holidays. We look at what else is going on around that time frame, and we try to build around it as much as we can. The due dates are real. Don't wait to submit your NCC the night of the due date, because we never know what's going to happen with the HP. There could be an outage, and that's something that we can't control for. Remind yourself of when things are coming. Quarterly reports, when we put them out there, they're out there for a reason. It's more of trying to make sure that things keep on moving and being an effective tool for us to monitor progress. The other thing is, if you have a large project, break it down to something smaller, small segments. I always think about it as running a marathon. If you're running a marathon, you're not looking at the 26.2 miles. You're thinking, I got to get through mile 1. I got to get past mile 2. I have to get to this point. It's always segmental, and a lot of times it's a game in the head. And that's kind of what you have to think of when you have a project. Plan for what's realistic. Build in some cushion. It helps.
And along with knowing your due dates, you don't want your grades to be a surprise either. Use continuous evaluation within the context of your program. We have worked, Caleb and Tracy and I all worked hard on the data collection, the PIMS data collection tool and the Flex program work plan data table to make those tools that you would have all the time in order to facilitate those reports that are due on specific due dates. But that Excel file, that's something that lives on your computer all year long and that you can update and check in with at a regular schedule. You don't need to wait until the PIMS report is due in September to be filling out that PIMS data collection tool throughout the year, so that when it comes to the September PIMS report, the data is conveniently and easily available to you. Same thing with the work plan data table. That's a once-a-year collection of outcome data for your Flex program, but that doesn't mean you only look at it once a year. Compass and the other FMT and InViQuip tools and resources also provide you opportunities for regular data checks within the Flex program. And it's important, and I try to keep this in mind all the time for national Flex program issues. Performance improvement does not just apply to the critical access hospitals that we serve. It really is something that we want to use actively within the Flex program itself as well. And the Plan, Do, Study, Act cycle is a really simple, straightforward, and effective tool for small-scale, rapid cycle performance improvement. It's that one step at a time adds up to major changes in the end.
I think that's a really great point, Sarah, that most, if not everything that we talk about as far as program and project management for the critical access hospitals is very applicable to managing the grant. You know, the Plan, Do, Study, Act, quality improvement efforts, relationship building, all of those things are applicable to both Flex coordinators and hospital administrators. So many of these things that might be a hospital resource, you know, posted as a hospital resource on the TASC website is just as applicable for critical access or for Flex coordinators.
Yeah, that's a great point, Caleb. And the last kind of piece of content to share today is to be sure that you're not going at it alone. The State Flex program is such a unique program. There's 45 different State Flex program coordinators in the country. That's it. But the impact that we make covering 1,300 or more communities with the work that you're doing is so vast, and there's so many different approaches, but there is that huge, that common thread of the program. So be sure that you're networking with your other State Flex program peers. We hope you had the opportunity to do so at the Flex program reverse site visit, or if you've come to the Flex program workshop recently and maybe made a connection there. But if not at any of those in-person events, including other regional or national conferences, please do connect in the Flex program forum. If you're unfamiliar with that, it's a secured location on the TASC website where there's only special access for State Flex program personnel to be able to send messages to the group or post comments or share documents or ask questions just with one another about Flex program activities. So it's closed for a purpose, and that's so that we can talk openly with one another and ask questions and not feel like we're getting preyed upon for opportunities to use our funds, or that we can talk candidly with each other. So we only have so many opportunities to see each other face-to-face every year, so please do use the forum to connect and share ideas or best practices, or certainly those lessons learned too. Be sure to reach out with programs that are doing similar work or in areas you'd like to explore. If you're curious about who might be doing something similar to you, most states completed their State Flex profile around the turn of the calendar year, which is again on the TASC website. And if you click on that, which you can find in the right side menu navigation, you'll be able to look at an individual state, say it's Iowa or Florida or wherever you want to look. You can also search those by the different questions. So you can look at everyone's responses related to the quality improvement work that they're doing, or everyone's responses related to network activities they might be doing. So do know that that's there, and it includes contact information for state flex program personnel too. So then you can reach out to somebody and ask questions and find out more or share what you might be doing that's similar or related. And lastly, be sure to network with partners, either existing or potential partners in your state that share similar healthcare interests. And I said healthcare interests on purpose because there might be other organizations in your state that are working on healthcare, but the rural component to the work that you're doing might not be part of it. That, some of the states in the FLEX program are more urban than others, and so their work might be very urban-centric, or you might yourself be housed in an urban center in your state, even if it's a rural state. And so your partners sometimes may be more urban-focused, but they certainly need to have the rural interest in mind and to be aware of the unique things that are happening in rural, be it that we might be lagging behind in particular things, but also the really cool work that's happening and highlighting how rural can be so innovative and nimble to things too. So do foster those connections, reach out and volunteer to be on different committees and organizations as it fits with your organization, as it fits with your role in FLEX too, to be able to share those stories or get new ideas to bring into your program as well. So with that, I think that what we'd like to do is just ask, if anyone has any questions about any of the content that we covered today, we welcome you to press *2 and unmute your phone, or certainly use the chat box as well. And if there aren't any questions, is anyone willing to share an example about how you may have celebrated some of the successes your FLEX program has had or your hospitals have had to partners or other organizations in your state? Anybody have an example of that you're willing to share? I know some of you do newsletters, which I'm assuming then go to many partners. Sometimes we get those newsletters too, which is great to see. Okay. Well, if no ideas on that, those are the types of things that are great to share in the forum. So if that comes up, or if anyone has any